Session 4. Professor Anis Fito, University of Florence, Italy. Inflammatory bowel disease, importance of early treatment.
Assalamu alaikum. Good afternoon, everyone, and great thanks to the organizer to invite me here, and special thanks to Professor Nagal Ahlam to invite me here. I guess I enjoyed the meeting so far. On the liver, we change a bit the focus now on inflammatory bowel disease. I will have 2 lectures in a row in the interest of time, also because I have a tight schedule to fly back to Dubai. I apologize for that. So, these are my disclosure. Well, the first talk is regarding treating early in the treatment of IBD, and the lesson comes from Crohn's disease. And this is probably one of the most abused and overused slides in the talk on IBD, just demonstrating the progression of the disease. So as long that more flare of activity of disease are accumulating, the disease progresses in terms of complication. And so for us, it's very important to treat early and, as I said, to catch the window of opportunity to avoid the complication and disability for patients. And this has been demonstrated in several controlled trials. The most clear, for example, is the CHARM trial with adalimumab. It was specifically designed to see the difference of the efficacy in terms of symptom remission according to the disease duration. So, and you see this in the gray, the pointer is not working that much, but you see in the gray column that it is very clear that the patient with a disease earlier than 2 years did much better than the patient with disease over 5 years. And in general, the early, the better. These were controlled trials. Well, this is exactly the same also in the real world. This is a meta-analysis pulling together several trials. It is absolutely clear that there is at least a 2-fold advantage by treating this patient earlier in terms of complication. And this is the case of TNF, but this can be applied to all the other biologic therapy. This is a very interesting trial they have done in several centers in Canada and US. There was a kind of a cluster analysis among the trials. So basically, the center were randomized and not the therapy. And the difference was there was a conventional treatment or eventually an early introduction of immunosuppressor. It was absolutely clear that in the center where there was an early introduction of immunosuppressor, there was a decrease of the complication in terms of hospitalization, surgery, and disease-related complication. So are you doing any better? See, this is a classical slide that was shown 20 years ago by the French group, Cosnes for its author, which is the progression of the disease. So early in diagnosis, 80% of patients have not complicated disease, but after 10 years, most of them modify the behavior in terms of stricturizing and fistulizing disease, which is much difficult to treat and leading in most of the cases to surgery. And indeed, we are doing better. So this is the experience, for example, in North America. And you see after 7 years of follow-up, only about 15% of patients change the behavior for inflammatory to most complicated cases. This thanks to introduction, and I will say also thanks to early diagnosis and the early introduction of therapy in this patient. This is an experience from Korea. And again, it's a prospective study just demonstrating the difference in introducing late or early therapy. In this case, early was defined within 3 years, the introduction of biologic therapy. And you see all the most important outcomes. They are also not only important for the patient, but also important in terms of a burden for health service, intestinal surgery, progression of behavior in terms of more complicated disease, stricturing complication, and penetrating complication. So all these very important outcomes did better with an early treatment. What happened in terms of surgery? So if you go back to the 50 and the 60, you see that up to 70% of patients with Crohn's disease underwent surgery. And indeed, even there, we are doing better. You see the more recent case down in the slides, although the surgery is still the case in many patients with Crohn's disease, we are now at something of 30% to 40% of incidence of surgery after 10 years of the disease. So point is, may we identify more accurately the patient have a more different and aggressive outcome and then treat them differently? And if we so, what we can do exactly in this population? So we know so far that there are some clinical factors that alert us in terms of more aggressive pattern, which is a younger disease, younger than 40 at diagnosis, the more extensive involvement and the proximal involvement of the intestine, the presence of extraintestinal manifestation, the severity of the disease as we can see at endoscopy. But there are also other biomarkers I wish to have more, to be more precise. So for example, ICRP, some serological markers, not only the classical ASCA, but also the more recent BIRS, for example, antibodies that have been in some way put forward, especially in North America, and some genetic markers. There is a lot of research there, but unfortunately only not two mutations so far is the strongest in terms of prediction. And this should be put in the context of what is now the strategy to treat this patient. So to not only to obtain and achieve the symptomatic response, that of course is the first target for the patient, go back to the normal quality of life, but also normalization of inflammatory marker, provide also the normal growth, for example, because 25% of these patients are in the children adolescent age, and also at the end obtain more robust marker of improvement, which is completely endoscopic healing. We are moving to histologic healing on ulcerative colitis. And in Crohn's disease, all this will decrease and will arrest the progression of disease and disability. And the next step for Crohn's disease is to achieve also the transmural healing as evaluated with the imaging. Now, what we can do in practice? So we should stratify the patient, eventually using a kind of dashboard, a kind of algorithm to see the risk factor, having a kind of dynamic tool to monitor the patient over time. This is a key point. We have to monitor the patient, not the way the patient come back when they are relapse or symptom. We have to educate the patient since early beginning. And we have to try to personalize them more than possible. In the next lecture regarding the biologic therapy, I will also focus more on that. We have to personalize more than possible the therapy for the patient. There are already some experiences come from North America, is so-called prospect tools, pulling together a number of serological, clinical, and phenotypic markers of the patient to calculate the risk factor of the progression of disease over time, and then eventually to be more aggressive from the beginning. And you can see in the single patient that can be evaluated. In this study, for example, it's been predicted that 80% of patients indeed have to moderate to high risk of progression of disease. So the minority of patients with Crohn's disease, 20% or so, even in population study, a very mild disease. So in most of the cases, we should expect the disease will progress. And if you see here, after 1 year, in the patient with a prediction of low progression, 10% already had a complication. And in patient with high risk of progression, already 1/4 have a complication. So we should treat accordingly to avoid this complication. This is another post-hoc analysis to eventually try to predict the efficacy of therapy. This has been done with the vedolizumab in patients with Crohn's disease, and basically calculating several variables that are very easy to calculate also in clinical standpoint. So the presence of bowel surgery, if there was a present therapy with biologic, there was fistulizing disease, the baseline albumin and CRP, and this author calculate a kind of score, and to the basis of this score was very easy to calculate the progression in terms of response to therapy, in this case by modifying the Arbeit-Bradshaw score. So the sooner the better, and this has been also once again underlined by the International OIBD Association, that from the STRIDE 2 move to STRIDE 1 move to STRIDE 2 recommendation. So it's important to us to fix the goal for the patient, evaluate over time, monitoring very carefully, and eventually modify the strategy if the targets will not be achieved. And it's clear that this is another meta-analysis of many studies. When we treat the patient, for example, in this case, within 3 years with anti-TNF, we modified significantly the risk of surgery. In this study, reduction more than 40%. We modified significantly the progression of disease, in this case, less than 60%. And once again, if we evaluate the damage of the disease, you may be aware of the so-called Lehman score or Lehman index, that is to evaluate the damage. It means the extension of disease, the eventual presence of resection already, or stricturing. So all these will put in the context all along the intestinal tract. And you see this is a study of under 30 patients with Crohn's disease that were evaluated with Lehman index already at the diagnosis. And they were evaluated over time. And it was absolutely clear that within 2 years, the patients that were treated more early with anti-TNF in less than 2 years had a completely different progression of disease compared to the others. So there are a lot of arguments that have been accumulating to stress us this importance of early treatment. Unfortunately, this does not apply to all the situations of disease. This is a very important study done in children in North America. And this, once again, are children that are treated very quickly in terms of disease. They treat with anti-TNF within 3 months for the diagnosis. And you see on the left-hand side of your slides, unfortunately the pointer is not helping me that much, basically there was a clear efficacy you see in the red curve when the patients were treated with anti-TNF, a behavior which is fistulizing disease. So they can prevent the progression of fistulizing disease. Unfortunately, in the patient with a behavior of stricturing disease, the blue curve, even if they were treated very effectively and early with anti-TNF, the progression remained the same because so far we have not good agents. They are good enough in those patients that are more fibrotic behavior of disease. So we can reduce the activity, the inflammation, but not the progression, because in that case there is a change in remodeling, a change in the metal proteins, and so far the biology we have in our hands are not good enough. This is another example of what vedolizumab eventually may do in terms of modifying the disease, and you can see the clinical remission, steroid-free remission, and mucosa bleeding is significantly different in patients with early compared to late treatment. So to sum up, and this is also the experience of the PROSPECT trial, in the majority of patients with Crohn's disease, the disease will progress and the damage will be reversible if not treated in time. And 50% of patients will develop stricturing, a complicating disease. Up to 1/3 of patients will develop a fistula. In some cases, perianal fistula is the major issue for this patient. So there are multiple challenges for the clinician. Unfortunately, we still miss very important biomarkers that can more accurately predict the course of the disease. But we have already in our hands some information and we have to treat already. So the future is eventually, because still in 1/3 of the patient, with any kind of biologic we're using so far, we have not satisfied enough of the progression. So the future is probably to think out of the box, as we say, so eventually to try a combination of biologic therapy. There are already some experience on that I will mention. There have been not a clear advantage in a combination of the classic immunomodulator with ustekinumab and vedolizumab. There have been not a great advantage, but there are a number of ongoing trials now to be more ambitious, especially in the patient more difficult to treat, eventually with combination of sequential therapy. And I will mention in the next talk. Do you see any different compared to Crohn's disease in terms of disease progression? We know that there is disease progression even there, and you see here, even if you classify it on the basis of the histological activity with the Gabor score, the higher the Gabor score, the more the disease will progress in terms, for example, of colectomy. But we have not such much proof of the efficacy, of the different efficacy, I would say, of the therapy early on in ulcerative colitis compared to Crohn's disease, probably because we are early in the diagnosis of ulcerative colitis. The presence of blood is very alarming for the patient. They run to the doctor, while more frequently in case of Crohn's disease, we can lose years because symptoms are very difficult to evaluate. This is a classical example, LOVE-UC study. So you see the difference in patients with early compared to late disease. At the beginning, there was a clear difference in terms of activity of disease. On the left side of the column, you see Mayo 3, so the more active disease was much present in patients with late disease. But after treatment, you see in both categories of patients, late compared to early disease, there was the similar efficacy. So in the UC, we still have not the same proof of evidence of Crohn's disease, but it's not a reason to wait more. So if I can go directly to the second talk, I will target directly which kind of biologic eventually we can use in our patient, since the landscape of the therapy is increasing quite a lot. So this is the third in the, and then eventually at the end of both lecture we can have some questions. Yeah, is that down? Very good. So we have a number of therapy they are already using so far, and you see here the agent they are using for the induction, the agent they are using for maintenance, and I'm pleased also to remind that smoking cessation is a very important kind of management that we have to use in patients with Crohn's disease. So the point is which one to use, and the landscape is even more complicated for the future. You see, since the early beginning, more than 20 years ago, the introduction of infliximab has been a breakthrough in the therapy for Crohn's disease and then for UC. And then progressively, what is coming to the future, already ozanimumab has been approved in FDA, coming all around the world, and risankizumab, upadacitinib, already used in other immune-mediated disease. The phase 3 of the in IBD that were approved soon also by the FDA. So for us it's very important to decide which kind of biologic therapy, which biologic therapy come first or eventually as when there is a failure. So are we to decide the sequence of the therapy in IBD, and I'm talking about biologic therapy? We can focus on the efficacy, we can also be interested in the safety, and we can also think about what next, because we know that at least in 1/3 of the case this therapy will fail. And so there is any clues to which one to select first. And I will take this argument one by one. So based on the efficacy, we can talk about the first line efficacy, the second line efficacy, and the comparative efficacy among studies. So regarding biologic, as I said, what we have already in our hands is anti-TNF, anti-integrin, at the moment only vedolizumab, and we have also the interleukin-12 and interleukin-23 inhibitor, so ustekinumab. They have both almost the same efficacy in Crohn's disease. Probably in ulcerative colitis, infliximab has a higher efficacy, and has been proved that vedo has a better efficacy compared to adalimumab. There are minor differences in terms of speed of action. All of them sometimes need a dose escalation, 25 to 30% of case, a different timing of administration, different way and route of administration, also different mechanism of action. They also have different immunogenicity, because for some of them, for infliximab specifically, we have to use a combination therapy because of the immunogenicity. For the others, there is no advantage of combo therapy. And as you know, and I'm sure also available in country, the availability of biosimilar is for sure a cost saving, also can increase the number of patients that can use this therapy. So regarding the anti-TNF, we know now that 30 to 40% of these patients fail at the beginning, what we call primary failure. Up to 50% of these patients will fail during the course of therapy, as a mean of 10-15% every year, despite what we try to optimize in terms of therapy. And this is simple because, first of all, there is a different response compared to the level of availability of medication in the serum. Not always we have the opportunity to check the TDM, although we should do more frequently for anti-TNF. And you see that more we increase the serum concentration, the more we can improve the mucosal healing, both for adalimumab and infliximab. Sometimes we stop the therapy because we miss this information, and we believe the medication is not working anymore, but it's just a matter to push further to increase the concentration. But for sure there is a problem there, which is the immunogenicity. So both of them, especially infliximab, but even adalimumab, as you see, this is a large evaluation done in UK, more than 1,000 patients, followed for quite a long time. And you see that the immunogenicity is consistent. So the presence of antibodies that, of course, will inactivate or will accelerate the clearance of the medication and in turn reduce the efficacy is substantial. Now, if we think about safety, all our patients are interested about safety. Is the first question I ask, doctor, which will be the consequence of any therapy, including biologic therapy? We know that thiopurine may give problem in terms of serious infection, opportunistic infection, more frequently viral. We know the anti-TNF as a monotherapy also have this problem, even a bit more than thiopurines itself. And in this situation, as I said, there's the infliximab, where you have to use a combination, we increase the risk. Although we can do better with therapy, but we increase the risk. And you see very easily in this graph. This table, to me, is very clear and is a very good message to bring back home in terms of which are the complications that we are facing with this patient and the safety we even to share with the patient in terms of risk of TBC, serious infection, herpes zoster, risk of lymphoma, demyelinization, deep vein thrombosis, and pulmonary embolism and hyperlipidemia. You see that there are class situations like for the anti-TNF, they are quite similar. And you see that for vedolizumab and ustekinumab, we have a quite better kind of safety window. And for tofacitinib, you see we have a completely different risk factor in terms of safety compared to anti-TNF. So this should be very clear to us and should be very clear in terms of communication to the patient when it's possible to prevention. There are situations in which we have not to use anti-TNF, for example, when there are already demyelinating disease or where there is within the family demyelinating disease because there is no a risk factor for that patient. In the older patient has been demonstrated increased mortality and also increased frequency of serious infection. In some cases, this therapy-induced adverse reaction that may lead to stop the therapy. We cannot use in more advanced cardiovascular disease and pulmonary disease or when there is a chronic risk of infection. So these are stopping rules to use anti-TNF. There are, however, very important safety data in terms of tolerability of vedolizumab. These are the data combining together all the control trial, Gemini 1, 2, and 3. And if you just concentrate on the last column, the table is very busy, but it's very clear that numerically there were more cases of adverse event in placebo compared to the patient treated with vedolizumab. Once again, underline that if the disease is not well controlled and the patient are with the standard of care and placebo, they run even more risk of some biologic therapy, specifically vedolizumab. The same can true also for ustekinumab. You see there, this is the data up to 5 years of the registration trial, Unify, Unity, and the long-term evaluation of this trial. And once again, numerically, you see a difference. There is no significant difference. Numerically, you see that in the placebo arm, they have even more adverse event, more serious infection compared to ustekinumab. So both this class of medication and for ustekinumab, we have even more information from the dermatological field. We are very sure of their safety profile. Now, the point is which one to start first. So this is a very nice network meta-analysis. When we miss the possibility to compare the study, there is this methodology to pull together the data. And this is very clear that we look to the clinical remission on the top or endoscopic improvement in the bottom. When there is a first failure with the biologic therapy that in general has been anti-TNF, the best choice is to use tofacitinib and ustekinumab. In this situation, vedolizumab doesn't seem to work that much. And this is another kind of network meta-analysis done in Crohn's disease. Again, when this patient failed anti-TNF, what is doing better is ustekinumab, and in some cases adalimumab. My personal experience is not such good with adalimumab, 10% improvement efficacy when they fail anti-TNF. Eventually, they can do better when the stop anti-TNF was due for adverse reaction. And this is exactly what has been demonstrated in this large study from Spain, more than 12,000 patients treated with biologic therapy, and more than 1,000 of these patients eventually moved to a second biologic therapy. They concentrate on anti-TNF, and they demonstrated eventually when the first anti-TNF failed, the second anti-TNF, and even eventually the third anti-TNF, has 40 to 40% efficacy. But this is the case eventually by adding combo therapy by adding also thiopurines, and it was the case especially when the change of therapy was due to adverse reaction, infusion reaction in most of the cases anti-TNF. Now, there is any difference in ulcerative colitis when we treat anti-TNF and use another medication. So this is the case of adalimumab. These were patients that were naive to anti-TNF or anti-TNF exposed. You see that there is quite a lot decrease of efficacy of adalimumab in patients that was anti-TNF exposed. The delta that we obtain in clinical remission response to mucosal healing is very low. The same can true for vedolizumab. Good efficacy anti-TNF naive, but when the patient has been anti-TNF exposed and failed, the delta of achievement is very low. Once again, also for ustekinumab, there is still some efficacy. So the point is not to treat, but unfortunately, the medication will work much less. In probably a bit less the case of tofacitinib. This is just a control trial. We wait some more information for the real-world study. This is the 8-week intention to treat population. Still, the delta there was, acceptable, but the placebo rate was such low in this subpopulation that make me a bit more suspicion and waiting more data. Is the situation in Crohn any different compared to ulcerative colitis? Pretty much the same. Even in Crohn disease, when the patient fails anti-TNF and we give adalimumab, we obtain some results, but much less if the patient are completely naive for anti-TNF. The same with vedolizumab. You see the efficacy is significantly lower. The same by using ustekinumab. The efficacy in terms of clinical remission and clinical response completely significantly lower compared to when you use anti-TNF. So for us, it's important to decide which biologic start first. And in this context, what can help us is the 8-to-8 comparison study. And many studies are running, many are also available for the future. For some, we have already some data. For example, we have the data of the Varsity trial. So by comparing the efficacy of vedolizumab with adalimumab ulcerative colitis, it's absolutely clear that there is at least a 10% of advantage, which is significant, and is something that we have to think about. There are already recommendations of the main guidelines that say that vedolizumab should be preferable to adalimumab as a first-line therapy in ulcerative colitis. These are the data not only anti-TNF naive, but also anti-TNF exposed, and these are the data, for example, of the endoscopic improvement. Once again, you see the difference. In contrast, this is another study in Crohn disease comparing ustekinumab to adalimumab. In this case, there was not clear difference. So eventually, in this case, what makes the difference is eventually there is a comorbidity. If this patient, for example, has psoriasis, and so in this case, we will prefer ustekinumab to adalimumab. You see, in terms of clinical remission, there is no difference, and the same can true also for other endpoint like endoscopic remission. So, as I said, the future is evolving to the combination therapy because the way the medication works is completely different according to different mechanism of action. According to the class, they can work directly on the cytokines, they can work in some cytokine compared to the other. They can modify the profile of cytokine as the JAK inhibitors, or eventually they can have a more broad anti-immunatory efficacy like cyclosporin and immunomodulators. This is an example of a triple combination therapy in a risk patient that look very brave, I would say aggressive, by using at the same time vedolizumab, adalimumab, and methotrexate in this patient. The study almost closed, probably will note by the end of the year. And we have some initial data. For example, this is combination from a study of University of Calgary and from California, San Diego. Few patients, you see 24, and basically the bottom line that 43% of these patients by combination therapy, most of the case was combined ustekinumab, vedolizumab. There was a 40% of improvement, 25% of endoscopic remission, and there was a clinical response and remission in 41% of the case. The adverse event, especially because they were used probably the more safe biologic, so vedo and ustekinumab was not such great. So The decision of treatment is in our hand. In most of the cases, we treat with corticosteroid at the beginning just to control the symptom for 1 or 2 weeks, complete the screening, complete the evaluation of the patient. Then we have a lot of options in our hands and a lot of combination among the different drugs. There are some clues that I'd like to share with you and just to bring home that there are some situations in which we can more easily make the choice of the patient and sharing with the patient this choice. In patients with more than 65 years, for sure we should prefer vedolizumab and ustekinumab for their safety. When we have an ulcerative acute colitis, there is no discussion so far. We have to use infliximab or eventually cyclosporine when there is a contraindication for infliximab, for example, possibly quantiferon. There is an history of cancer or lymphoma. Then in this patient, the best choice could be to use vedolizumab and ustekinumab. During the pregnancy, tofacitinib is contraindicated. We have not that much data for ustekinumab, probably safe as the others. I will not talk about teopurins at the moment. If there are extraintestinal manifestations, of course, we should prefer medication which are more proof effective, like anti-TNF and tofacitinib. And there is a previous anti-TNF failure. As I said, there is a clear difference for ulcerative colitis. We should prefer tofacitinib and ustekinumab, while for Crohn's disease, probably only ustekinumab is doing better. So, of course, you have to take in consideration the availability. In some countries, there are restrictions to access to the first line compared to second line therapy, but the future will be even more complicated with more medication. And we have to move to personalized medicine. We have to move to try to identify which is the predictive factor specifically for that patient. And for sure this will be the case as has been for the oncology already so far. This is my last slide. It's time to be more ambitious in inflammatory bowel disease. We can do much better than we did 10 or 20 years ago. It's important to diagnose the patient timely, to evaluate the risk factor and to prognosticate the future and to modify the therapy accordingly, to have some goal of treatment and check this goal if we are achieving and monitor the patient very carefully. That to me is more important recommendation. And of course react. If we see that therapy is not working, there are complications, the patient is not satisfied, we have to react accordingly. And with that, I really thank you for your attention.
Thank you very much for the highly updated presentation. Even I found some studies even published March 2022, the head-to-head studies. It's a very elegant presentation actually, but actually I have a concern about the IBD progression and I want to know your point of view about this. As you mentioned, the strategy for treating IBD passing from the stride 1 to the stride 2 in the time framework, the monitor of the IBD passing from the active to the proactive, even to the ultra-active, and I think the very much number of biologics and small molecules which is now available, the personalized approach for elderly, for pregnancy, and so on. Why we still found that there is a great number of patients, or there is no decrease for the percentage for surgery and hospitalization for our patients?
Yeah, well, that's a very important point. So the point is that probably most of the patients that we still see have a diagnosis since many years and probably have not been treated timely. So we still the carry-on effect of the disease that has been not well controlled for years. And at that point, any kind of biologic therapy will not work more than that. That's why even the target of the therapy should be different if there is an early diagnosis of a patient already 10 years of the disease. In patients with 10-year disease, we cannot pretend or really hope that there is a complete regression in terms of transmural healing. So some changes in the bowel will remain there, some stricture will remain there, surgery probably has already been done. So again, we have the fortune, and the patient have the fortune that the future is much more bright than 20 years ago. So the point is to make which kind of therapy use. And to me, more important, we can mistake the right therapy. What is important to monitor accurately. So if we very timely check again if there is any progress, any advantage, don't wait too long. Eventually you have to change.
Do you find the important item, which first biologic we use, like different studies mentioned nowadays? If we start by VIDU, we can, the patient can carry long-term remission if we use it in naive patients, or a very short remission if we are using after using of anti-NF and so on. You found it's considered to be a factor like that for a possible complicated Crohn's disease, or we didn't get the target that we need for such patients?
I'm not sure I get your question, sorry.
I'm talking about the selection of the first biologic.
Yeah, so that's very much even country dependent. So, for example, in France, they have no choice. They have to start with anti-TNF. So if we are in the situation, I actually am working in UAE, in the situation where we can use all the biologic as a first-line therapy. There is no, pretty much the same cost, so there is no any restriction from the insurance company to start one or the other. So that's the situation that we should personalize the more than possible the therapy. So the route of administration, the speed of action, the presence of exintestinal manifestation, the comorbidity, the age of the patient, some specific setting, perianal disease compared to a no perianal disease, all this information should guide the clinician to the right choice together with the patient. So the patient may prefer have an administration every 12 weeks, but if you have perianal disease, probably I would say, well, in your case, you have very severe activity of disease, it's better you come to do an infusion in the hospital, and I check you more closely. So it's very much dependent patient by patient and situation.
Okay. Any other questions for Professor Vito? Any other question? Yeah.
Okay, first here, okay. Mike. Okay.
Young patient with complicated Crohn's disease, you prefer start treatment sit up or up down or top down?
Top up.
The first question. The second question: what is the endpoint? What is the optimal endpoint of treatment in Crohn's disease with complication? Thank you.
Yeah, well, I will say, once again, this is a matter also of label. So basically, all the biologic registered so far are being labeled to be used when there is a failed of conventional treatment. So theoretically, we cannot start straight away with the biologic therapy. Basically, we have a bit of time, which is a couple of weeks, to complete the investigation, to make all the screening tests, and then eventually we may force the indication of biologic therapy. In most of the case, young age, extensive disease, I do start very quickly with the top-down therapy, if you wish, with biologic therapy. Eventually, for just a couple of weeks of steroid, it's simple say that, well, there was not effective, there was adverse event to steroids, and we start biologic therapy. Unless there are situations where the disease is very limited. So you may be aware that there has been a trial called LYRIC trial when the disease was limited just to last 10 to 20 centimeters of the terminal ileum with a stricturing behavior with no response to steroid. The patient were randomized to have anti-TNF or a resective laparoscopic surgery. And apparently, in terms of quality of life, in terms of outcome, there was not that much difference. So in limited disease, especially with stricturing behavior, surgery is still an option. It's a very good option for Crohn's disease. And eventually, we prevent the recurrence of the disease. But as you say, in the example of an aggressive disease at a young age, how we start with top-down therapy, the point is, again, for the insurance, for the healthcare system, that should be in some way, argumented, because actually the label is that we can use the biologic therapy when there is failed of conventional.
Please, yeah.
I didn't get
Optimal end point of treatment.
Well, again, that's depend from the disease. the endpoint of ulcerative colitis is completely different from Crohn's disease. On ulcerative colitis, we are moving to histological healing now that we can probably reach in 20% of the patient. Once again, this applies to the patient with the more early disease. In Crohn's disease, we are happy when there are no ulcers. So the presence still of erosion of aphthoid lesions should not change the treatment. We cannot pretend in all patients with Crohn's disease to achieve the transmural healing. And it's very much different, as I said, if an early disease of 10 years. So we should be also realistic of what we can achieve.
Please.
Okay. Yes, to catch your flight. So just comment if you have a comment, and he has to catch his flight. Okay.
What about biosimilar in inflammatory bowel disease?
Biosimilar are here.
First question: what is the management of
biosimilar here to stay? Because the patency expired, so the biosimilar are in the market, are produced by the same big company of the originator. There is proof of evidence that they're absolutely the same. It's a great opportunity for the patient and for the health service.
But what about the best management of co-infection or co-diseases, autoimmune hepatitis, severe autoimmune hepatitis, with a biological treatment? What is the solution? As some of these biological induce more autoimmune hepatitis?
Well, there is, to my knowledge, no report of any detrimental effect of autoimmune hepatitis. So, in general, all the immune-mediated diseases share some common mechanism. So, with few exceptions, there have been no, for example, there are some medication used in some oncological setting. There have been induced some a flare of Crohn's disease or even de novo IBD. But in general, when there is immune-mediated disease, even the combination of biologic therapy, I've seen a patient we using combination biologic therapy because one was not covering both the disease. I've not seen any, I'm not personal case, I'm not aware of personal report in the literature of autoimmune hepatitis and IBD. I will not consent to use the biologic therapy.
Yes, with autoimmune hepatitis severe with ankylosing spondylitis, and our rheumatologist asked us what is the best biological treatment. So through the research, I identified only this is treatment for oncology, interleukin-2 receptor agonist, but it's not valid. What's your recommendation in such case?
Well, sometimes the treatment they do for spondylitis or treatment they do for Crohn's disease cannot cover the autoimmune hepatitis. So probably this patient can have a combination of thiopurines eventually and the biologic for in the case of spondylitis or IBD. But I will not concern with the detrimental effect of biologic on autoimmune hepatitis.
Okay. Thank you, Dr.
Thank you
Vito,
so much.
and have a nice flight, inshallah. Now the next speaker, Professor Henrich, consultant of gastroenterology and interventional endoscopy, Switzerland, and the interest in motility disorders of the upper and lower GI tract. We'll start under interventional treatment of motility disorders. Ready for prime time?
Thank you so much for your kind introduction. I hope you can all see my slides. I've not received a notice that I'm not being heard or seen, so I'm just going to continue. What I'm going to give you today is a ride through the GI tract and the options that have come up for endoscopists to possibly treat some conditions that have been usually reserved for surgeons. So I'm going to go into that territory a little bit. I have no conflicts of interest to declare. So what am I going to talk about? You see lots of pictures here. I'm going to talk about the esophagus and motility disorders of the esophagus. Everyone knows the picture of achalasia, of stasis of food in the esophagus, but also the classic picture of esophageal spasm or nutcracker esophagus. What is a little bit extreme is the picture below, of gastroparesis. These are the 4 topics where I'm going to delve into a little bit more, because their endoscopic treatment has definitely advanced in the last years. So, talking about the esophagus, there has been tremendous work done by the Chicago group in classifying motility disorders. I'm not going to go into every detail of this very, very complicated graph with lots of numbers and values, but what I want you to take home from this is that there are 2 things to consider when you look at a manometry. For one, it's the presence of disorders of EGJ outflow obstruction and disorders of peristalsis. And the disorders which are approachable via endoscopic therapy are achalasia and EGJ outflow obstruction. What also might be within the scope of endoscopic therapy are spasms and hypercontractile esophagus. I'm going to go into that a little bit more. So these 2 things are the ones that you need to keep in mind. All the complicated numbers and yes and ifs are for the aficionados of high-resolution esophageal manometry. So what is the utility of manometry for the diagnosis of severe motility disorders, i.e. the ones that can be treated either via an endoscopist or a surgeon? So this is a landmark study with 1,000 patients with classic reflux symptoms that were sent for manometry. And what this showed is that more than 5% had severe motility disorders or achalasia. So it's really important to perform those and to see what's going on. If you then use high-resolution esophageal manometry or even high-resolution impedance manometry, so adding an information about emptying of the esophagus, you can increase your diagnostic ability to detect this motility up to 30%. So manometry is crucial for diagnosing a major motility disorder. So always use it before treatment. So talking about the one motility disorder that we all know by heart in the upper GI tract, that's certainly achalasia. Here you see a normal swallow with the upper esophageal sphincter opening, initiating the swallow with the peristaltic wave, and before the bolus reaches the stomach, the lower esophageal sphincter has to relax. In achalasia, this is all a little bit different. And in a landmark study by John Pandolfino in 2008, 3 types of achalasia were able to be distinguished via high-resolution esophageal manometry. So you have type 1, where basically nothing happens between the upper and the lower esophageal sphincter. What's also important, the lower esophageal sphincter does not relax. In type 2, there's some activity, but that's usually pan-esophageal. So not a proper peristaltic wave, but either a pressurization of the content. Also, the EGJ does not relax. Type 3 is what we would call spastic achalasia before, and there is no EGJ relaxation. So these 3 types are important because they have a different success rate when they're treated either endoscopically, with Botox, by dilatation, or even with helomyotomy. The first 2 types of achalasia actually present the 2 types that are best approachable by any sort of treatment. Type 3 remains a challenge. This is the study which summarized what I've just said, that type 1 and 2 generally have a more favorable outcome when you look at giving Botox, dilatation, surgical myotomy, and other treatments. Type 3 is generally the type, so the spastic type of achalasia, that has outcomes that are not beneficial. So what do we have when it comes to the treatment of achalasia? We have lots of stuff, but for the endoscopist, medication certainly is not interesting. Botox is reserved for very frail elderly people and has to be done again. So I would rule that out. So the big competition at the moment in treatment is balloon dilatation, which has been shown effective, halomyotomy, the classic, and endoscopic therapy in the form of peroral endoscopic myotomy, a technique established by Ino et al., which has been shown to be very successful. There are some studies which compare the gold standard of halomyotomy to POEM, which start to show very favorable data, i.e. that POEMS is equal with regards to long-term resolvement of dysphagia and improvement of the Eckert score, but as usually you cannot perform an additional reflux procedure yet with your POEMS, you have more reflux. In most cases, the reflux is mild and can be handled with a low-dosed PPI therapy. There are a few cases of severe reflux after POEMS. But what is also important to know, and this has become into focus with recent studies, is that you, the endoscopist, and the surgeon are not mutually exclusive. You can still help each other. So, for example, if a surgically performed myotomy is not complete, an endoscopist can still complete it. Or if you have a severe reflux after POEMS, a surgeon can still add 180 rep to help with the reflux. So I think the approaches are feeding into each other and offer great opportunities for the future. Moving on to the tricky subject of the EGJ outflow obstruction. So not achalasia, but a problem with the opening of the lower esophageal sphincter. This can be sometimes very tricky to be distinguished from achalasia type 3. What is important is that you still have a peristalsis-like movement and an elevated IRP. It is also important to rule out that there's a structural reason for this picture, i.e. a tumor or other diseases, so paraneoplastic achalasia, for example. Once you've ruled that out by imaging or EUS, you can move on to treating. What is also important is to investigate the patient properly. And this has been shown in a couple of very elegant studies that position matters in the diagnosis of EGJ outflow obstruction. If you investigate patients in the supine position, you have a high rate of false positive rates of EGJ outflow obstruction. If you have a very high rate of false positives in the supine position, if you put patients upright and give them a provocative test, this cannot be confirmed. And also, it is usually not confirmed on barium esophagogram or endoflip, which is a new distensibility measure of the GOJ. So it is important when you see EGJ outflow obstruction in the supine position to make your patient sit up and give him a proper meal to really see if what you're looking at is actually not only a false positive. So the majority of EGJ outflow obstructions in the upright position are confirmed pathological. So watch out how you diagnose EGJ outflow obstruction. So is POEM a new treatment for spastic motility disorders? So looking at EGJ outflow obstruction, nutcracker, hypertensive spasm in the esophagus. It is tricky because type 3 and spastic disorders don't respond well to any sort of treatment. If you look at the data, it becomes apparent that it is important to look at the manometry and determine the length of your myotomy, either via Heller's or POEMS, which is now the more chosen approach, by the height and length of the peristalsis you see on manometry. The treatment success for type 3 is a little bit better than for hypertensive or spastic motility disorders, and the data is not really very, very large. So this is an area of investigation. So type 3, yes. Spastic motility disorders, maybe. What about the endoflip? Can it help us in any way to improve our outcomes when endoscopically treating achalasia? Does it help the surgeon? Does it help the endoscopist? Well, there is a couple of data out there that endoflip can determine the subtypes of achalasia. In patients with aperistalsis or stasis on barium swallow, but no IRP elevation, the endoflip can show the reduced distensibility. So in debated cases, endoflip can be useful to finally make the diagnosis of achalasia. And after Heller, a poem, there is some data that endoflip can predict reflux, but this has not really been shown in studies that are large enough. You see the numbers below. We're talking about studies which included 8 patients or 11. So that is not enough. We need to up the data on this. After Heller, the decrease of the distensibility index, so the DI, can predict the improvement of the Eckert score, so the improvement of dysphagia and regurgitation in achalasia. So there is something there. Moving on further down from achalasia and spastic disorders of the esophagus to the stomach. This is now a very extreme example of gastroparesis, but we all have these patients that have been suffering from diabetic gastroparesis, idiopathic gastroparesis, or post-surgical gastroparesis. They usually suffer greatly. And what is also important to say that sometimes, in a lot of cases, the delay in gastric emptying is not really congruent with symptoms, and also with any treatment you choose. The improvement in gastric emptying does not always reflect in an improvement of symptoms. So let's have a brief look into that overlap of gastroparesis and functional dyspepsia. It's not, is it the same, but different? There are news. There is a huge overlap in symptoms and in pathophysiologies. Medication, post-infectious, and idiopathic can be found in functional dyspepsia and GP. So these two entities can present the same and have a lot of similar symptoms. And there's now a new study published in the end of 2021 in 900 patients, with 60% patients with gastroparesis, 24% with functional dyspepsia. They were enrolled in a multi-center registry over a 12-year period. And what this very impressive data shows, in the end, when you looked at it over time, patients with gastroparesis and functional dyspepsia were virtually indistinguishable when you were looking at clinical characteristics and the severity of upper gastrointestinal symptoms, which somehow promotes the idea of a common pathophysiology. How do you manage these patients? Usually patients get managed with improvement of their diabetic medication, losing weight, medications which usually don't work. And at some point, the surgeon or the endoscopist is called. There are several options on the table. So pylorotomy, which has a very high technical success rate, but is very invasive and time consuming. The electrical stimulator has not been followed through. There's a little bit of data on it, but not enough. Endoscopic options so far have been Botox. It's easy, it's tolerable, but needs to be repeated. But it can induce nasty sclerosis and anatomic alteration of the pyloric region. And pyloric stent placement for anyone who's ever done it has a high risk of migration. So the new kid on the block seems to be G-poems. So the similar concept that is used in poems, creating a submucosal tunnel, going on to the pyloric muscle and cutting it. This technology is gaining more track and is becoming more popular for patients with diabetic gastroparesis, but also idiopathic gastroparesis and post-surgery gastroparesis. There are some studies which show in small numbers of patients that there is an improvement in PACSIM and GCSI, so the symptoms and the quality of life. Also, emptying and flip measurements improve. And during last week's UEG, an interesting abstract from the very active research group in Prague presented their interesting data on a randomized controlled sham-controlled study on GPOEMs, which reported success rate of more than 70%, especially in the group of patients with diabetic gastroparesis. This data is certainly very positive, but it also gives hope to a group of patients which is usually quite desperate for a way out of their debilitating symptoms. So I think GPOEM is the new kid on the block that we need to keep an eye on. We certainly have a big toolkit of measurement tools like manometry, and certainly also the endoflip, which can be used in a transpyloric way to measure success or determine pylorospasm to better understand the effectivity of this treatment. So, moving to the end of my presentation and now to the lower part of the GI tract, what about POEM in the anal canal for Hirschsprung's disease? This has been very new. There's a study with 8 patients from India reporting a good success rate in kids with Hirschsprung's disease performing a myotomy in this area. So there might be interesting developments there, but 8 patients are certainly not enough to make this a standard treatment. And it certainly hasn't been compared to the usual pull-through surgical techniques. So this is something maybe to keep an eye on. In conclusion, we have new tools in our kit, in our physiology kit, like manometry, endoflip, and gastric emptying studies with scintigraphy or breath test to guide treatment and to predict treatment response. POEMS is certainly established for achalasia and for EGJ outflow obstruction. Spastic esophageal disorders are still a little bit on the fence with a little bit of debatable success, but I think if you base your endoscopic treatments on your manometric findings, you might also improve your outcomes. GPOEMS is certainly a promising tool. There's lots of exciting research coming out which will help those patients suffering from gastroparesis or functional dyspepsia. As for PREM, this is certainly too early to judge. And I thank you for your attention, and I'm open for questions.
Thank you. Any question? Please. We have one question from the floor now. Professor Enrita?
Yes.
Us? Okay, we have one question, please.
Yes.
Perfect.
Professor Harriet, we know that POEM usually complicated by reflux. According to PREM, the complication of stool incontinence, it is common or no available data about this?
I think it's very hard to say and to compare because the studies are usually very, very small for PREM. And also after transanal pull-through, there's a significant rate of incontinence. So I wouldn't be actually able to comment on that, whether the incontinence rate is less after PREM. I think this will have to be shown in further studies, whether it really performs better than the other surgeries. And as to bile reflux, I think any sort of reflux gets worse with POEM because you basically destroy significant fibers in the GOJ. What often is the case, and that's something that I see in my practice, that patients also have a little bit of gastric emptying problems with achalasia, and these problems usually do not improve after POEMs because you don't do anything about the sphincter. So some surgeons, before their helemyotomies, they also perform pyloric dilatation, and that's maybe something to look into. Because I think part of the reflux might also be due to impaired gastric emptying. But what I said before is true. The reflux is a problem, but it can be treated. And if you make patients aware about it and tailor the treatment to your patient, explaining surgery, POEMs, all the options on the table, then usually in the end you will find a combined pathway to treat these patients. And it's usually a lifelong pathway because achalasia is a progressive disease and probably not done with a POEM once you've had achalasia. You will have to have further treatments. So it's important to stay on the case with these patients.
Thank you.
Please, I have question.
Okay.
Okay.
Another question, Professor Henry?
Yes.
What about gastric biopsy in motility disorder or gastric motility disorders? Gastric biopsies, yeah. Thank you.
I think gastric biopsies are not, they will not go deep enough to really see whether there's a motility problem. There's very scarce data on, for example, full thickness resection specimen in gastric emptying problems. What I know is being done in achalasia and gastric emptying and achalasia and gastroparesis is actually taking biopsies from submucosal space to see whether there's a problem with the neurons. So this is something that one should look into, but with gastric biopsies you will A, not go deep enough, and B, only maybe also miss the relevant part of the disturbed motility. So I think gastric biopsies are probably not sufficient.
Okay. Thank you, Professor Everett, and hope to meet again.
Yes,
and now,
thank you.
Thank you very much. And now the next session. Thank you for all our colleagues and professors, and thank you.
Welcome to the Symposium of Global NABI. We'll talk today about refractory Gerd. Is it only a proton pump inhibitor resistance? My agenda of my presentation will include an introduction to Gerd, what's refractory Gerd definition, causes, how to interpret, the diagnostic test for refractory Gerd, how to treat, and summary and conclusion. As we know, Gerd results from prolonged contact of the gastric contents with the mucosa of the esophagus secondary to disruption of the anti-reflex barrier. The cardinal symptoms of Gerd are two: acid regurg and heartburn. Sometimes this is accompanied by chest pain and dysphagia. BBI still represent the first line of treatment for treating Gerd. However, up to 30% of patients will not respond to the standard dose, which is single dose once daily. If the patient needs 2 doses and still give no response or partial response, this is considered as a refractory Gerd. So refractory Gerd is defined as persistent of the typical symptoms of heartburn and regurg that do not respond to the standard BBI once daily, or incomplete or partial response less than 50% to double the dose of PPI after 12 weeks of treatment. What are the mechanisms underlying refractory Gerd? This could be something related to the medication given to the patient, including leading to insufficient acid suppression. Either the patient has poor compliance with PPI timing and adherence, or there is a difference in the Bbi metabolism or residual acid reflux. Another cause could be a big volume of weakly acidic or alkaline reflux, or the esophagus could be very sensitive, what we call it esophageal hypersensitivity. Sometimes in 58% we have what we call it functional heartburn. An alternative diagnosis for refractory Gerd include achalasia, esophageal eosinophilic esophagitis, infectious esophagitis, pill esophagitis, gastroparesis. Sometimes, and last, obesity and H. pylori may have a role in the refractoriness of the GERD. Insufficient acid suppression, if we take it one by one, for maximum inhibition of proton pump, it should be given 30 to 60 minutes before breakfast. This provides a better control of intragastric pH compared with administration during or after a meal. Differences in the Bbi metabolism. BBIs are metabolized through the hepatic cytochrome system, dominantly CYP to C19. Slow metabolizers are those which do not metabolize drug, leading to greater suppression of the gastric acidity. However, in rapid metabolizer, the effect of PPI on the gastric acidity is diminished and may contribute to PPI failure. Sometimes a pocket of concentrated acid secretions are found near the gastroesophageal junction at the fronts of the stomach. This could be one of the causes, we call it pocket. This could be one of the causes of refractoriness of the GERD. And another cause is the occurrence of weakly acidic but greater reflux volume. If we put a balloon inside the esophagus and start to inflate, the degree of inflation is associated with the initiation of the symptoms of GERD. So esophageal balloon distension causes sensation of heartburn in patients with GERD that increase in a linear fashion with increasing balloon volume. Esophageal exposure to bile salt also causes heartburn. Esophageal hypersensitivity. Reflux hypersensitivity is characterized by retrosternal heartburn and the chest pain associated with non-pathological acid exposure. Symptoms are triggered by the proximal migration of weakly acidic reflux despite normal acid exposure on pH or pH impedance manometry. Functional heartburn. Functional heartburn represents 58%, as I mentioned, in cases of refractory GERD with persistent heartburn despite the optimum BBI therapy. And alternative diagnoses include achalasia, esophageal eosinophilic esophagitis, infectious esophagitis, Bell's, gastroparesis, rumination syndrome. And these are the causes, different causes of non-GERD, of other symptoms that might simulate refractory GERD: achalasia, eosinophilic esophagitis, reflux-like dyspepsia, and gastroparesis. Obesity and H. pylori, as I mentioned, could be another cause of refractory GERD. What is your approach to a case of refractory GERD? First step, we have to assess the drug compliance and the adequacy of lifestyle modification. Number two, we have to switch to another PPI or increase the dose of PPI to BID. Next step, we have to investigate. Is it structural or functional defect? These are the different causes of the structural and functional. The structural, we do endoscopy and barium swallow. The functional causes, we investigate by high-resolution manometry, ambulatory pH, impedance manometry, endoflip, and gastric scintigraphy. When to do upper endoscopy in cases of refractory GERD? Upper endoscopy is indicated in individuals with additional risk factor for GERD, like increasing age, NSAID intake, smoking, family history of upper GI cancer. If you want to exclude other serious conditions like esophageal carcinoma, in those who have failed to respond to the initial BBI, when alarming symptoms like weight loss, anemia, dysphagia are present, and if you suspect for the presence of parotesophagus. The value of upper endoscopy, however, in refractory GERD is limited in patients with NERD. I mean the patient who do not have erosive changes or functional heartburn. However, endoscopy and the biopsy could be beneficial in identifying eosinophilic esophagitis, Barrett's esophagus, and peptic ulcer. It could differentiate other non-GERD causes. Biopsy could also reveal the mechanism underlying the GERD symptoms. Even narrowbanding image enhance microvasculature and the mucosal pattern, not usually visible with a normal white endoscopy. What are the investigative tools in refractory GERD? We have to do ambulatory esophageal pH manometry, esophageal impedance manometry, high-resolution manometry, endolumen or endoflip, high frequency. How to manage refractory GERD? Current management algorithm for patients with typical GERD symptoms is centered around multi-channel intraluminal impedance pH monitoring. Before refractory GERD can be considered, one should ensure that a BBI regimen is adequately dosed and timed, patient compliance with the regimen is confirmed. Symptoms are typical of Gerd, I mean heartburn and regurg. Symptoms are not located in the epigastrium or in the throat area. Multi-channel intraluminal impedance pH monitoring, combined with an analysis of the symptoms occurrence reported by the patient during the measurement of can categorize the refractory Gerd patient into 3 groups independent of their acidity. A group with abnormal acid exposure, refractory Gerd, those represent 16% of patients. Gerd symptoms are triggered by ongoing acid reflux. This is a habitual type of reflux. Non-acid reflux Gerd represent 25 to 27% of this patient. Non-acid reflux, as I mentioned, could be alkaline or acidic, but in a big volume. Ongoing symptom cannot be attributed neither to the acid nor to the non-acid reflux, and they represent around 58% of cases. Treatment of refractory Gerd. In patient with persistent acid reflux on multi-channel interluminal pH monitoring, we have to assess compliance with BBI intake both in terms of dose and timing. Stronger or long-acting acid suppressive drugs than currently available one can provide a better symptom relief in patients with poor response to adequately dosed BBI. We can change the BBI. We have 3 types of modification to the BBI, either to double the dose, or to give the extended release BBI like dexlansoprazole, or to switch to another BBI like pantoprazole magnesium, or esomeprazole, or rabeprazole instead of omeprazole. Add-on drugs like alginates, Gaviscon is an example of this, or if the impedance pH monitoring is positive for weakly acid reflux, we have to give drugs that reduce transient lower esophageal relaxation, like GABA B agonist, baclofen is an example, but it has many side effects as it crosses the blood-brain barrier, causing drowsiness and nausea. Cholecystokinin receptor antagonist, gastrin and the cholecystokinin receptors are identical, as a selective cholecystokinin receptor blocker antagonist can suppress the acid secretion, or we can give potassium competitive acid blocker like sorabrazone and linaprazone, etc. Those drugs show a linear dose-dependent pharmacokinetics similar to BBI. Prokinetics, etopride, musapride, brocalopride. These drugs improve the esophageal peristalsis, accelerate the acid clearance, particularly in patients with diabetes and patients having hypomotility, increase the lower esophageal basal pressure, and improve gastric emptying. They are, unfortunately, they are not so safe. Some of them may cause prolongation of the QT interval. They have several significant adverse effects, and their use in Gerd has been limited by the concern about their safety. BBI and prokinetics, only prokinetics can add a marginal improvement in the BBI action. Etopride is relatively a better one. It's a prokinetic agent that acts by 3 mechanisms. It inhibits acetylcholine esterase. It antagonizes dopamine 2 in the gut, and similarly it acts on the chemoreceptor trigger zone in the brain. All of this will culminate in increasing the lower esophageal sphincter pressure, stimulate gastric emptying and GI peristalsis, accelerate gastric emptying, improve gastroduodenal coordination, provide an antiemetic effect through their action on the chemoreceptor trigger zone. Etopride do not cross the blood-brain barrier, so no CNS side effect. It had no cardiovascular effect, and there is no drug-drug interaction with other drugs. Pain modulator, this group of drugs, which we call it visceral analgesics, are usually needed in the majority, in some patients having functional Gerd. Visceral analgesic, tricyclic antidepressant, and serotonin receptor reuptake inhibitor may be valuable in NERD patient, functional heartburn, especially in patients with hypersensitive esophagus. They are used in non-mood altering doses. يعني بندي for example citalopram 10 milligram is quite enough. The other drugs to be added is ribamycin اللي هو اسمه في السوق Micosta, has an anti-inflammatory function, is a mucosal protectant. Pain modulator for refractory Gerd, reserved for patients, as I mentioned, with negative testing, acid-sensitive esophagus, functional heartburn. Anti-reflux surgery and fundoplication. These drugs reduce the hiatal hernia into the abdomen, reconstruct diaphragmatic hiatus, and reinforce the lower esophageal sphincter. Anti-reflux surgery, by increasing the basal lower esophageal pressure, decreasing transient lower esophageal relaxation, and inhibiting complete lower esophageal sphincter relaxation, lead to reduced acid and non-acid Gerd. But is it indicated for every patient? Patients who benefit from fundoplication are those responding to reporting complete or at least partial response to BBI before surgery. ولكن they desire an alternative therapy because of the drug expenses, or they have a poor medication compliance, or they are fearing of the long-term effect of the drugs. What about the outcome of the anti-reflux surgery? The outcome of the anti-reflux surgery in patients with complete BBI response was better than those with incomplete response. So a rigorous patient evaluation before fundoplication is mandatory. Testing to be done before anti-reflux surgery. We have to do upper endoscopy, perium, esophagogram, esophageal manometry combined with impedance, 24-hour esophageal pH testing, fasting serum gastrin level. This is a fundoplication. 360 درجة is a much better one. It should be done by an experienced surgeon in a center who have a big experience, who have done the operation for 100 times. Complication of fundoplication include dysphagia, gas ballotment, diarrhea, heartburn, regurgitation. Data concerning BBI after anti-reflux surgery. Lodrop et al. Estimated that as many as 50% of patients become BBI user في خلال من 10 إلى 15 سنة بعد العملية، يعني العملية ما تستمرش على طول. Other novel techniques, surgical and endoscopic, include transoral incisional endoscopy performed fundoplication, or Lennox magnetic sphincter tightening of the lower esophageal sphincter, endostimulation, electric stimulation of the lower end of the esophagus, Medigas SRS. A transoral incisional endoscopically performed fundoplication is safe, effective, and durable alternative to surgical procedure. Magnetic sphincter, our Lennox, we put a titanium plates at the lower end of the esophagus, having placed laparoscopically. The magnetic attraction between each bead augmented the pressure on the lower esophageal sphincter, but not to the extent to occlude the esophagus. It could allow the passage of food. It had no serious side effect. Endostem, as I mentioned, electrical stimulation laparoscopically to the lower end of the esophagus to augment the sphincter tone. Medicus and Strata. Strata is not available anymore, and it was drawn from the market due to the side effect. This is a complicated, somewhat summary, but I will jump directly into the summary and conclusion. Patients with refractory Gerd are those individuals whose symptoms do not respond to a stable double dose of BBI during treatment period of at least 12 weeks. Refractory Gerd patients should be evaluated, and the other treatment options should be considered. BBI modification, like doubling the dose or switching from one BBI to another with more stronger acid suppressor effect, could be effective in controlling Gerd symptoms. Add-on therapy like Coil, lower esophageal sphincter relaxation, baclofen, or antidepressant drugs may help. Antidepressant drugs are potentially effective neuromodulatory therapy for patients with refractory Gerd. Data suggests that anti-reflux surgery has a lower efficacy in refractory Gerd than in the usual Gerd. The experience with novel endoscopic or surgical technique are limited, and their application require a large-scale study. Thank you so much.
Bismillahirrahmanirrahim. It's my pleasure to be part in this session, Advanced Intervention and Endoscopic Technique. Welcome for all chairperson. I would like to welcome Dr. Hakan for his presentation, Intervention in EOS 2022. Dr. Hakam.
Thank you very much. Dear colleagues, it's always a great pleasure to be in Egypt. And yesterday we had a great day in Menofea. I was impressed by the cases as well as the experience of the gastroenterologists. Today, I am going to summarize the data in relation to interventional EUS 2022. My presentation will be around 45 minutes to 1 hour. What should we do before attempting interventional endosonography? These points are very important for the people who are attempting to start interventional EUS. First of all, the patient should be informed completely. Patient as well as the relatives should be prepared for the worst case scenario, surgery, ICU, and even death. And you should have an experienced team. And you should be experienced as well, of course. And you should know from the very beginning what you are going to do. However, in these procedures, these are highly dynamic procedures, so from the beginning you may not estimate everything and you may change your strategy while performing the procedure, but you should have a solid aim. And be ready for the unexpected and do not panic if it happens. Have all the necessary accessories available. And try not to rush to the surgeon at once. If complication happens, try to fix endoscopically. However, have a collaborative surgical and interventional radiology team. While performing these procedures, we are meeting the challenge from interventional radiologists because they are performing what we are doing with different techniques, such as targeted biopsy, neurolysis, percutaneous drainage, percutaneous biliary drainage, all these. So in the case in your institution, there is an established interventional radiology team. In the beginning, it may be challenging. And we are also meeting some challenges from surgery as well, because they are performing most of the procedures we are doing endoscopically or endosonographically. For example, gastrostomy. And furthermore, surgeons mostly prefer interventional radiologists rather than gastroenterologists. And at the end of the day, complications may require surgery. So you should have very good relation with the surgical team. When we are talking about diagnostic EUS, the perforation rate is low, but it is still present. For example, in a diagnostic endosonography, there is 0.3% esophageal perforation risk, 0.6% gastric duodenal perforation risk, and bleeding, significant bleeding, hematemesis melena, or more than 2 gram deciliter drop of hemoglobin, is happening between 0.1 up to 1%, and pancreatitis up to 3%. So we should understand that even diagnostic EUS is an invasive procedure. When we come to interventional EUS, the overall complication rate is 25%. necessity for surgery 5 to 10%, and procedure-related death rate is 2 to 5%. This is a case just happened in my institution while teaching a trainee, and he told me in duodenal bulb, he is somewhere which is not lumen. This is a perforation site with therapeutic echoendoscope. What I have done is that I used an over-the-scope clip and closed the site. And after this closure, for this patient, we went on with ERCP and stone removal. So we managed it quite successfully. And in my unit, while teaching the trainees, I encountered such duodenal perforation in 10 years in 6 cases. And I closed the perforation site in all 6 cases with over-the-scope clip. So you should understand that while performing these procedures, you should have accessories, you do not panic, and availability of an experienced endoscopist is a bonus for you. As to cystogastrostomy, what is new? Actually, now most of the endoscopists are performing endosonography-guided EUS drainage. This device, Hotaxios, is a single-action device. You see, we go into the cyst directly with electrocautery. We put guide wire. Actually, it is not necessary in all the cases. Then we open the distal part. We withdraw it until the distal flange is just like a golf ball. And then we deploy it without endoscopic view, only with radiology. And actually, the deployment of this Hotaxios stent can be done without C-arm. So only with EUS assistance, you can do these procedures. And it will take at the most 10 minutes. Now, Taewung and Hanaro companies are also producing devices similar to this. Hotspaxus from Taewung and a similar one from Hanaro will be on the market. So probably in the future, we are going to use this kind of stents. But, this is an important but, the price is very high. For example, this Hotaxios stent is around 3,000 euro. Because of this, in most of the cases, I use alternative stents rather than this very expensive stent. We can drain any part of abdomen, even it is very near to thoracic area. You see, this is a collection just between diaphragm and spleen. So it is in subphrenic space. It's a necrotic collection. We performed the procedure from cardia, very near to esophagus, you see. "19-gauge needle, guide wire, dilation with 6 French cystotom, and finally deployment of a fully covered stent. So you see, here is esophagus. We can drain such kind of collections to cardia or esophagus. Even we drain sometimes mediastinal collections. For example, in some patients, you see, we are withdrawing it, and it is better placed. Sometimes we drain mediastinal collections in this way as well. So no limit. This is an interesting case, a very large collection. We put the fully covered metallic stent for drainage. It is in stomach, you see. But after one day, it migrated into the collection. So what to do? We identified the stent under US. We entered into it with 19-gauge needle. We put a guide wire. This is the proximal part of the stent. And after putting guide wire, we dilated the tract, put a double pigtail stent through it, and then when we pulled the double pigtail stent, the metallic stent came out with it as well. So in most of the time, if something unexpected happens, we try to find ways to fix it by endoscopical means. Whenever there is a peripancreatic necrotic collection, even it is in early weeks of pancreatitis, rather than endoscopy, percutaneous or surgical necrosectomy, we prefer endoscopic necrosectomy. We put a guide wire through a 19-gauge needle, and we dilate up to 20 millimeter, so a very large opening. We then put mostly an enteric stent with 20 millimeter diameter. We go into the cavity. This is the necrotic cavity. And using net, stone extraction basket, sometimes snare, we try to remove all the necrotic tissue in 2 to 4 sessions. All these sessions should be at least 1 week apart. If there are some necrotic areas, necrotic debris, we cannot remove with cold techniques. Sometimes this is a percutaneous drain, you see. We sometimes grasp with snare, and we even administer electrocautery. But in this procedure, bleeding is not rare, you see here. So whenever bleeding happens, we try to stop it with hemostatic means. If not possible, we put clips. In our institution, between 2013 and 2018, we performed endoscopic necrosectomy for 14 patients. Mean age was 53, and males were predominating. Mostly idiopathic, some hypertriglyceridemia, biliary, and alcoholic. 5 of these 14 patients died due to multi-organ failure, but 9 patients survived, and no serious adverse event due to necrosectomy happened. So, if you have enough experience, I suggest endoscopic necrosectomy over percutaneous or surgical necrosectomy. And because in our institution, surgeons noticed that we are having less adverse events. They are also referring this patient for endoscopic necrosectomy rather than surgical necrosectomy. When we come to biliary drainage, actually, as I said yesterday, in Manometry, we had very, very interesting 4 cases for US-guided biliary drainage, but I still want to remind you what we are doing. In this patient, we were not able to cannulate papilla retrogradely, but we were able to put a guide wire through choledochoduodenosstomal site. Then we grasped the guide wire with a duodenoscope. We withdraw the echoendoscope first, of course. Then we put a sphincterotomy over the guide wire, and we perform ERCP. This is US-guided ERCP, and the so-called rendezvous method. We use this rendezvous method especially for the patients with benign etiologies. For example, there is a stone, but we cannot cannulate, then we do this. But very recently, for the patients with stones, we cannot cannulate. I performed choledochoduodenosstomy first with a metallic stent, then waited for some time for the resolution of papillitis, then performed ERCP. And after that, after 4 weeks, when I removed the metallic stent, no complication happened. So for benign causes, we are increasingly using this method as well. But in most of the time, if the etiology is not benign, a malignant one, when we insert a guide wire into the common bile duct, we perform choledochoduodenosstomy rather than rendezvous, because choledochoduodenosstomy is simpler than rendezvous technique. This is an ERCP catheter. Dilation, not absolutely necessary. In yesterday's case, we did not perform actually dilation. We put the stent right away. I am sorry. This is the bulb. Fully covered stent, and bile is gushing out. However, sometimes the things may not go as you expect. In this patient, you see the opening from the bulb, dilation. But while putting the stent, something unexpected happened, and guide wire dislodged from the common bile duct. Inevitably, we removed the stent, and I closed the site because it was large with hemoclips, and then I moved to hepaticogastrostomy. But hepaticogastrostomy was not possible because the ducts were not significantly dilated. Furthermore, there were metastases. And in this case, I resorted to rescue cholecystogastrostomy. So in distal obstruction, if choledochoduodenosstomy fails and the gallbladder is in situ, I use this technique, and I call this as rescue cholecystogastrostomy. So you cannot drain anything. You fill this biliary system with contrast. You are going to either send this patient for percutaneous, or you can do this. So rescue cholecystogastrostomy is an effective method for failed choledochoduodenostomy. And a quite successful drainage. This is from our last Middle East North Africa meeting. This is a patient with Klatskin tumor, just I think at the bifurcation, and bismuth type 2. So it is dividing right and left. In this case, we first go into the left ducts, and then from left ducts, we insert the guide wire into the right ducts. And between the right and left duct, this is the right, this is the left. And common bile duct is not apparent because there is a complete obstruction here. We first put an uncovered stent between right and left and bridge the right to the left. And then we put an hepaticogastrostomy stent from the left to the stomach. So in this way, we drain both right and left ducts. This is called as bridging technique. This patient presented with common hepatic duct obstruction due to malignancy. We performed hepaticogastrostomy, and we were able to insert the guide wire into the duodenum. And we put the stent antegrately. Actually, yesterday we performed such a case in Menofea. We insert the stent. This is the end of the stent. You see here. So it is in bile duct. And we opened the stent in duodenum. We call this technique is antegrade stenting. And afterwards, we withdraw everything altogether. There is no need for closure of the stomach side because it immediately, spontaneously closed. This is called as antegrade stenting. In this antegrade method, we can also apply other techniques as well. For example, for this patient, there is a distal obstruction, but we cannot go from the distal side to the duodenum. It is completely obstructed, no flow, and guide wire cannot be inserted into the duodenum. So we end up with putting an hepaticogastrostomy stent, but after 3 weeks, we return and this time we are able to insert the guide wire into the duodenum. This is a radiofrequency catheter. Over the guide wire, we insert the radiofrequency catheter and we administer radiofrequency ablation to this site, to this cholangiocarcinoma site first. Then we perform balloon dilation, and finally we put a stent. So we can do whatever we do with ERCP, with EUS as well. Another patient with hepaticojejunostomy and a very large hepatic stone. Because of hepaticojejunostomy, we cannot reach papilla. Sorry, because I am trying to be a bit yes, a very large stone in hepatic duct. So we first perform an hepaticogastrostomy in this case. After 3 weeks, we return and we insert spyglass through the hepaticogastrostomy site. We insert it to the common hepatic duct and we perform laser lithotripsy for the stone. Actually, it took some hours. And after disintegrating the stone and opening the hepaticojejunostomy site, you see this is extraction balloon. We push it, the remaining stone parts into the duodenum. We are pushing the extraction balloon, in this case not extraction, but pushing device into the duodenum. And then we removed the stent and the patient recovered without any adverse effect. Another such case, I think this is very similar, so I skip this one. For acute cholecystitis, not amenable for surgery, in the past we refer all these patients to surgeons, but nowadays, for acute cholecystitis who are not eligible for surgery, we perform cholecystogastrostomy instead of percutaneous cholecystostomy. It is easy and a very rewarding procedure. We can do it either from the bulb or antrum. A successful cholecystogastrostomy. As I said, in all these procedures, something unexpected is very usual, as it happens in this patient. We performed hepaticogastrostomy, successfully inserted the stent. You see, stent is working very well. But unfortunately, it migrated inside. So it is not in stomach anymore. What to do? We tried several methods. First, we were unsuccessful. But afterwards, in radiological guidance, I identified the stent in peritoneal cavity, and from that site, I performed a needle knife perforation of stomach, and under radiological guidance, through the peritoneum, I put the needle knife. I am trying to reach the stent. Yes, finally, from the peritoneum, I reached the stent, and I put a guide wire through the needle knife. Then I put a bridge stent. So in most of these cases, we are trying to solve the problem without resorting to surgeon. But sometimes it may be inevitable. Another case, again, hepaticogastrostomy, very successful. But afterwards, it migrated inside. We find the site, balloon dilation, and withdrawal of the stent from the peritoneal cavity with forceps. Another one. Again, hepaticogastrostomy is successful, but I think that the stomach part is not enough in, so it is not working. I grasp the stent, but the stent is not in stomach anymore because it migrated inside. Then again, with 19-gauge needle, we find the way, put a guide wire, and again put a bridge stent. So from this, I suggest that when the stent is in a place, do not force your chance too more. You remember the saying that the worst enemy of good is perfect. So you should be content what you have done, if it is okay. When we compare US biliary drainage with percutaneous biliary drainage, actually it appears that US biliary drainage is better because the adverse event rate is less and need for reintervention rate is less as well. So we should prefer endoscopic drainage rather than biliary drainage. What about pancreas? In this case, we were not able to cannulate pancreatic duct, even if it is highly dilated. We inserted a 19-gauge needle to pancreatic duct from stomach. We administered methylene blue stained contrast. Then we noticed that the opening is in the minor papilla. From the oozing of the methylene blue stained contrast, we identified minor papilla and performed sphincterotomy with stent insertion. Another similar case, dilated duct, but we are not able to cannulate. We insert 19-gauge needle, inject contrast, but contrast is not going into the duodenum. Again, methylene blue contrast, we perform needle knife to minor papilla with a porcelain tip needle. And when we see the gush of methylene blue stained contrast, it means that we are in the right place. Again, porcelain tip needle. For minor papilla, because of the high risk of perforation, I prefer porcelain tip needle. Another case, again pancreas divisum, but complete obstruction and hugely dilated main pancreatic duct. Again, contrast, but in this case, because of complete obstruction, I was not able to go from minor papilla. So I punctured main pancreatic duct from bulb. And then from bulb to the main pancreatic duct, I inserted a metallic stent. This is called as Virsungo duodenoscopy. So we can do not only Virsungo choledochoduodenoscopy, but Virsungo duodenoscopy as well. Then, because there were stones, we inserted an spyglass and performed pancreatic stone laser disintegration from this side. We can do drainage to afferent loop syndrome. You see this patient have undergone an operation for stomach, and afferent loop was completely obstructed. And for this patient, we drained the afferent loop very easily. It does relieve jaundice because you see common bile duct is opening into the afferent duct. When it is obstructed, the patient presents with jaundice. And after the procedure, complete decompression of afferent loop. The same can be done to Roux syndrome. After a Roux and Y surgery, the Roux loop is completely distended and the patient is jaundiced. In this case, again, we perform from jejunum insertion into the Roux loop, and we put a stent into the Roux loop. So for afferent loop and Roux loop syndrome, the best remedy is endosonographic. You see this is jejunum, endosonographic drainage. And finally, I am going to talk a little bit about US-guided gastrojejunal anastomosis for gastric outlet obstruction. So you would ask what is wrong with duodenal stent. High migration rate, tissue ingrowth and occlusion, risk of papilla-vatery obstruction-related pancreatitis, obstruction of potential ERCP route, unsatisfactory clinical response, and sometimes obstruction may be impossible. So even if we want to insert a duodenal stent, we cannot insert even guide wire. And when these events, these procedures are considered, it appears that the best one is endosonographic gastrojejunostomy. And when compared to surgical gastroenterostomy, US-guided gastrojejunostomy is having at least equal results without a need for surgery. Very high technical success and clinical success rate. However, adverse events are very high. And even in experienced centers, the adverse event rate is between 7 to 27%. Need for surgical intervention, 13 to 33%. And procedure-related direct mortality, 2 to 5%. And adverse events are strongly correlated with experience. If the endosonographer performed less than 15 cases, the complication rate is very high. But more than 40 cases, successful procedure rate increases. And in this study, the authors collected the multiploid stents, and it appeared that multiploid rate is very high, up to 10%. And they divided this into several types. For example, the stent in stomach is okay, but not in intestine, so free here. Damage to jejunum, and the stent is in peritoneum. The proximal end is not stomach, and even the stent may be accidentally put into transverse colon. It is very easy to confuse transverse colon. I am going to show you a case of mine. So, in these cases, in US-guided gastrojejunostomy, the patients should be followed up very, very, very closely. For example, if after the procedure there are some signs suggesting peritoneal irritation, then you should immediately perform endoscopy to see what is happening, of course, after a CT examination, and if necessary, surgery. If you wait, then the result will be the death of the patient. And even in experienced centers, such events are happening in 1 in 10 patients. Previously, actually, we started performing US-guided gastrojejunostomy some 4 years ago. We first used this special balloon. This balloon is 2 separate balloons, and we put it through the duodenum into the jejunum. We identify the contrast field balloon. We insert a 19-gauge needle. And mostly I use enteric stent rather than lumen-opposing ones, because lumen-opposing is very expensive. And after 7 days, even after 7 days, you see a very successful gastrojejunostomy site. But later, because I have found this technique very demanding, it takes too long time, and in some patients, because of the stricture, it is very difficult to go into the jejunum through the duodenum. I decided to perform direct freehand technique. And you see in this case, even again in MENA meeting, from stomach, I identified the just proximal jejunum. It is the jejunal ans after 4th part of duodenum. I put a guide wire, dilate the tract with 6 French cystotom. And I put an enteric stent, 20 millimeter to 8 centimeter. And then we insert a balloon and open the stent more. After 3 to 4 weeks, a fistula develops, and even if you withdraw the stent, the fistula will be open. This patient actually had undergone Whipple procedure, but after short time after Whipple procedure, gastrojejunostomy site, surgical gastrojejunostomy site was closed, obstructed. From the stomach, we entered into the jejunum, put a metallic stent, enteral again, and balloon dilation. In this patient, after 3 weeks, the stent was expelled from anus. But when we go into the stomach, what we see was that a very well-developed gastrojejunostomy site. So if the stent migrates spontaneously, it means that the fistula has already developed. So no worries. What about the presence of ascites? In general, presence of ascites is considered a contraindication for US-guided gastrojejunostomy. However, it is not absolute. And this is a patient of ours. With ascites, we perform gastrojejunostomy. And you see now we inserted the 19-gauge needle to an intestinal loop. But this intestinal loop is not looking like jejunum. Why? Because it is transverse colon. So when we notice that this is transverse colon, we do not put stent, otherwise it will be mal-deployment. We withdraw and we find the actual jejunum, and we put the enteric stent. In the last 5 minutes, I am going to talk a little bit vascular endosonography. Actually, we perform biopsy from every vascular site from thrombosis. Actually, 2 months ago, when we were again in Menofea, we performed portal vein a biopsy from portal vein thrombosis from a guy, and it appeared to be benign, and the patient now, I have heard, is in very good health. So in order to differentiate benign and malignant causes of vascular thrombosis, we perform biopsy from either portal vein or going to finish it. This is gastric varicelle coil injection. Very large gastric varices, 19 gauge in the needle. For this patient, we put 3 to 20 coils of different sizes, again, MINA meeting. A very safe technique and very effective technique. We do it very frequently. Portal vein pressure measurement, feeding vessel obstruction, even splenic artery aneurysm management. These can all be done with vascular endosonography. Cardiac applications, maybe in the future we are going to do this more. Investigational procedures, selective portal vein embolization, portal vein stenting, and even intrahepatic portosystemic shunting. This is a pig model, and intrahepatic portosystemic shunting with EUS. Actually, this is a case of mine. You see, I did not perform EUS-guided. That will be the first human case because of the medico-legal concerns. But you see that it is not very difficult. This is cava, this is portal vein. So if I insert a 19-gauge needle here, I can put a stent between these vessels easily. Why didn't I do it? Because of the medico-legal concerns. However, technically, it is very easy. And in the future, we are going to have better devices. For example, now we are doing all this procedure with 19-gauge needle, but with these accessories, even these can be done through the 22-gauge needle. Radiofrequency application to insulinoma, and even microwave ablation. So, in conclusion, Chairman and colleagues, EUS-guided vascular access, even with 19-gauge needle to either vein and artery, and even cardiac chamber will be probable in the near future. Several diagnostic and therapeutic procedures are possible. It requires a true knowledge of EUS vascular anatomy, furthermore courage. Medical legal concerns and cost may be limiting. However, probably the next step in interventional EUS will be vascular intervention. Coiling arterial aneurysms, feeding artery embolization in uncontrolled bleeding, and EUS-guided tips. All the vascular, I'm sorry, this is Turkish, I think. All the gastrointestinal anastomosis will be managed by the EUS and EUS-guided microwave ablation. Thank you very much for your attention.
Thanks a lot, Professor Hakan, for this marvelous illustrative talk. We thank you a lot for sharing your expert knowledge, and you make a new indications of interventional AUS. We learned a lot from you, and we hope you see you all the time in our National Liver Institute. You're welcome in Egypt every time.
Thank you, and actually your unit is an excellent unit. I am very proud to be a temporary part of your unit. Congratulations.
Welcome you every time in Egypt. I would also want to ask Professor Dr. هشام حمزة ودكتور أشرف البوهي شركة بنتكس للمناظير for their very support to our unit and our workshop. We want to thank them all.
I think we can take one or two questions because he's in a hurry to get his flight. So we can take questions.
Thank you very much, Prof. Hakan. In brief, in your center in Turkey, now no patients for BTBD, percutaneous transhepatic biliary drainage after AOS, and you don't use cyanoacrylate injection for gastric fundal varices after coil through AOS, and the new indication now for AOS tips, portosystemic shunt. So AOS in the future can replace tips. Thank you very much.
Thank you for these perfect questions. Actually, for the last 2 years, I did not refer any patient for PTBD, but surgeons did. Actually, as I said, surgeons sometimes are preferring, and there is a paradigm that proximal obstructions should undergo PTBD, but that is not true anymore. But I did not refer. But in case everything is going very bad, so still you will need PTBD. But it did not happen in the last 2 years. The second question, we do not inject at the present moment glue after coil because we compared it, and coil in itself is equal to glue. And actually, we sent this paper to Arab Journal of Gastroenterology, and Abdülmecit Kasem kindly accepted it, and it will appear in the journal in the very near future, comparison of with or without glue. And the last question, yes, I hope that in the future we are going to perform portosystemic shunting through EUS, and as I show you, technically it is not difficult, but you see, because of the medical-legal concerns, we are a bit reluctant, because once these cases are going to court, some of the physicians, many of the physicians do not know about this, and they would say that, oh, they performed investigation, and they would be a headache. Otherwise, technically possible.
Professor Hakan, just questions about your cases. First, as regards using the needle knife in the migrated stent in one of your cases, why you used the needle knife, not the cystotome? The second question, do you prefer cholecystoduodenostomy or cholecystogastrostomy? I think cholecystoduodenostomy is safer because of it is retroperitoneal rather than the cholecystogastrostomy, and what type of stent, fully covered of course, and what type of stents do you prefer? And the third question, as regards the vascular intervention, as regards thrombolytic treatment of thrombosis like superior mesenteric vein occlusion, could we use streptokinase, for example, for lysis of the thrombus in recent thrombus in the superior mesenteric vein? Thank you. By US, of course.
Yes, thank you very much. I am going to start with the second question, because I don't remember the first one. The second question for gallbladder drainage. For gallbladder drainage, we either use cholecystogastrostomy or duodenostomy. Yes, duodenostomy is better, but it is difficult to keep the scope in duodenum. So technically, cholecystogastrostomy is easier, but if you are enough experienced, you will do cholecystoduodenostomy as well. Lumen opposing stent, if it is available, it is the best. But if it is not available, completely covered, biliary stent with large phalanges can be used. And for vascular procedures, I mean for thrombosis, injection of streptokinase and these other agents is of course possible, but you see that you are going into a vascular area, you are injecting an anticoagulant, so while withdrawing, it may be a problem. And because of this, it can be done, but the tract should be closed with something, either with fibrin glue or coil, but you see that in case you put a part of coil into the vascular area, so you can increase the thrombosis. For thrombosis resolution, I think it may not be the perfect technique. Your first question? Needle knife. Yes, for this case, you see the stent is in peritoneum. So in order to go into the peritoneum, first I should perform a perforation. So I see the nearest side to the stent. I perform the perforation with needle knife and then go into the peritoneum. Why not cystotome? Because cystotome is an over-the-wire technique. If you put the wire, then you can put 6-branch cystotome over the wire. But in this case, there is no wire. Thank you.
Professor Hakan, can we make use of AUS for in the era of hypersplenism in patients for hypersplenism in cases of to do partial splenic embolization?
Yes.
Hypersplenism, yes, it's a problem because the catheter treatment is quite painful and many side effects.
Yes, actually, very recently, such a paper appeared in Gastrointestinal Endoscopy. Selective splenic artery embolization through the 19-gauge needle, like deployment of coil, is possible. This paper is a pilot study. But in the future, of course, splenic artery selective embolization may be done. Yes, this is a novel method.
We can prepare such cases next time you come to us?
Yes, of course. This is not like US guided tips. We can do it.
Okay, thanks a lot.
Thank you.
Okay, thank you.
Next speaker will be Professor Dr. Gasser Al-Azab, one of our best professors in National Liver Institute. He will talk about endoscopic, bariatric, and metabolic therapies.
Thank you, Mr. Chairman, for this nice introduction. Good afternoon, everybody. Gastroenterologists were not involved in obesity management However, a few years ago, with the introduction of some FDA-approved devices and procedures, now we can manage obesity and involving in weight reduction procedures. As you know, obesity has become a global epidemic with sizable socioeconomic and health care associated burden. Intensive lifestyle intervention and pharmacotherapy are associated with only 3 to 6% of total weight loss. On the other hand, bariatric surgery is associated with almost 33% of total weight loss. However, only 1% of eligible patients actually end up undergoing bariatric surgery because of many reasons, including cost, risk, and even patient preference. In recent years, bariatric endoscopic procedures have been developed for patients with obesity who are not eligible for or don't desire bariatric surgery. So the endoscopic bariatric procedures lie in the middle in the obesity management spectrum, with efficacy better than medication and lifestyle, and with risk better than surgical procedure. Almost the risk is similar to the other intervention endoscopic procedures. So what is the indication for bariatric procedure? PMI should be between 30 and 40 in most of the cases. The patient tried to lose weight through non-surgical methods with no success, or don't like to do surgical interference, or require bridge therapy for other surgical intervention. There are many contraindications like prior bariatric gastric or esophageal surgery, large hiatal hernia, esophageal motility disorder, IBD of upper GI tract, pregnancy, varices, coagulopathy. Generally, the endoscopic bariatric and the metabolic therapies are classified into two general groups: gastric therapy and small bowel therapy. The gastric therapy are effective in treating obesity, but small bowel therapy, beside losing weight, are very effective in treating some metabolic diseases with variable weight loss profile depending on the device. So let's start with gastric procedures. We have many, of course, gastric procedures, but the most important are 4: intra-gastric balloons, transpyloric chatter, aspiration therapy, and endoscopic sleeve gastroplasty. Let's start with intra-gastric balloons. Of course, intra-gastric balloons have been used for the last 20 years with a large body of evidence of short-term efficacy and safety. Intra-gastric balloon facilitate weight loss by reducing stomach potential volume, inducing early satiety and returning gastric motility. It also causes reduction in gastric hormone secretion, such as cholecystokinin and pancreatic polypeptide, that cause delaying gastric emptying and improve glucose metabolism. It also may change the appetite-regulating hormone, decreasing hunger and greater weight reduction. We have many intragastric balloons, but the FDA-approved balloons are 3: Orbra and Reshape and Obalon. The Orbra intragastric balloon is one of the most widely used balloons in the United States and Europe and Middle East. It previously was known as a bioenteric intragastric balloon, BIP. It has been approved in the United States since 2015 for patients with BMI between 30 and 40. It is a saline-filled single balloon with a volume ranging from 400 to 700 milli. It's implanted for 6 months and required endoscopy for replacement and removal. An open-label multi-center study showed that patients who made lifestyle modification in addition to intragastric balloon had estimated weight loss of about 10% compared to 3% in the lifestyle-only group after 6 months. However, after removal of the balloon, balloon group gained some weight. However, at the end of 12 months, still there's a significant difference between both groups. The reshaped intragastric balloon is two separate balloons connected by flexible wire. It was approved by FDA in 2012 for also patients with BMI between 30 and 40 with one obesity-related comorbidity. The two balloons are placed endoscopically and filled separately with 450 millimeter of normal saline dyed with methylene blue. And the idea of dual balloon design is to reduce the migration of balloon and also to fit the curvature of stomach for better tolerance, and also it lasts for 6 months only. The Apollon balloon, the third balloon with FDA approval, it's a gas-filled balloon that's swallowed by the patient. No endoscopy is needed for placement, but it needs endoscopy for deflation and removal. It's filled with a volume of 250 millimeter, and we can insert up to 3 balloons within 3 months and lasts also for 6 months. It was approved by FDA in 2016 for patients with BMI, again, 30 to 40. The fourth balloon is approved in Europe, but still under trial in US. Sparks Gi intragastric balloon. It's a spherical silical saline-filled balloon inserted endoscopically, but it has a thin-filled catheter that permits intragastric volume adjustment, so we can do adjustment of volume upward for more weight gain, weight loss, and we can downward the volume if the patient can tolerate the balloon. And it also has advantage that it lasts for 12 months instead of 6 months. So this is a summary of intragastric balloons for the weight loss and metabolic benefits. The 3 balloons FDA approved for 6 months, it causes excess weight loss, almost 30%, while the Sparks 3 intragastric balloon, almost 50% excess weight loss. And besides weight loss, intragastric balloon also proved to have many metabolic benefits, improved in metabolic parameters like fasting blood glucose, triglycerides, LDL, and diastolic blood pressure, and significant reduction in ALT and GGT in patients with NASH. The second gastric procedure is transpyloric shutter, and this device consists of 2 silicone-based bulbs. The large one prevents the device from migration. The small one is moved freely by the peristalsis to enter the duodenum. It causes intermittent obstruction of the pylorus and delay the gastric emptying. There was an initial safety concern because it caused a lot of gastric ulcers, but it has been redesigned and currently FDA approved very recently for a treatment period of 12 months. This study demonstrates excess weight loss, about 25% after 3 months and 41% after 6 months. Again, gastric ulceration was a common device-related adverse event which necessitates device removal in 10% of patients. The third gastric procedure is aspiration therapy, and this aspiration therapy involves endoscopic placement of percutaneous gastrostomy tube, similar to feeding gastrostomy tube, allowing partial removal of almost 30% of total ingested calories. The Aspire Assist system is FDA approved for use in patients more than 21 years with BMI of 35 to 55. Patient perform aspiration 20 minutes after eating, which take about 5 to 10 to 15 minutes. In multi-center trial, the pathway trial, the mean excess weight loss at 1 year was 31.5 compared to 10% lifestyle group only. The procedure, of course, is not patient-friendly, and it has a lot of adverse events, including post-operative abdominal pain, nausea, vomiting, and infection, even peritonitis. The last gastric procedure is the endoscopic sleeve gastroplasty. And endoscopic sleeve gastroplasty is a minimally invasive procedure in that full-thickened sutures are placed along the greater curvature of the stomach using overstitched device to create a restrictive sleeve that reduces the size of the gastric reservoir, as you can see in the imaging picture at the right. A large study contained about 1,600 cases reported from large multi-center study found that the total weight loss ranging from 15 to 17, a long period of 18 months. In total, the severe side effects were only 1.1 with total of 18 events. Again, obesity-related comorbidities such as hypertension, diabetes, and hypertriglyceridemia have been also shown to be decreased in patients undergoing endoscopic sleeve gastroplasty. And now the question, what is the difference between endoscopic sleeve and laparoscopic sleeve gastrectomy? Both are restrictive procedures that lead to weight loss by reducing the size of stomach. However, the laparoscopic sleeve gastrectomy involves surgical resection of 2/3 of stomach to provide increased satiety and decreased appetite, while the endoscopic one used plication to create a sleeve-shaped stomach. Of course, studies showed that the endoscopic sleeve showed decreased adverse event, decreased length of stay, decreased lower rate of morbidity, and decreased gastrointestinal reflux, while the laparoscopic sleeve showed greater weight loss. So let's now go to small bowel procedures for weight reduction. We have many also, but the important two is duodenal mucosal resurfacing and endoluminal magnetic partial jejunal diversion. The small bowel therapies, beside weight reduction, it causes improvement in the metabolic parameters. So let's start with duodenal mucosal resurfacing. It consists of hypothermal ablation of the duodenal mucosa via a balloon catheter with subsequent regeneration of healthy new mucosa. The idea of duodenal mucosal resurfacing is that the duodenum is important for regulating metabolic homeostasis, and alternation in the mucosa may affect glycemic metabolism by insulin sensitization effect. It's assumed that the duodenum is starting abnormal signals to endogenous insulin-sensitive tissues. As such, the process of desurfacing allows the mucosa to regenerate, restoring normal signaling. Duodenal mucosal resurfacing is used for patients with type 2 diabetes with an oral anti-diabetic medication with glycated hemoglobin more than 7.5. A reduction in glycated hemoglobin has been noted following treatment in obese and non-obese subjects. And this is first multi-center and open-label study showed a reduction about 1% in glycated hemoglobin, and also other benefits like the reduction in fasting blood glucose, reduction in HOMA-IR, and reduction in weight. So it may be a potential target for treatment of diabetes mellitus beside the oral treatment. The second procedure is endoluminal magnetic partial jejunal diversion. The idea is to create side-to-side anastomosis between ileum and jejunum using magnetic anastomosis system. The magnets are deployed in the jejunum and ileum and form anastomosis through necrosis of the adjacent tissue. Partial jejunal diversion allows food and nutrient to bypass most of the small intestine and enter directly into the ileum. This provides a method for weight reduction. This study was conducted on 10 patients and showed that the partial jejunal diversion that was created on all patients with no device-related serious events, the average total weight loss was 14% of the total weight. This equal to 40% excess weight loss at 12 months. Significant reduction in glycated hemoglobin was also observed in all diabetic patients, 1.9%, and pre-diabetic, 1%. So how to choose the right procedure for your patient? If you have a patient that tried lifestyle and medical therapy with no success, then you have to estimate the target total body weight loss for metabolic optimization. If you need a total body weight loss high, so you have to think about surgery and consider patient preference and surgical feasibility. If he is fit for surgery and is willing to do surgery, then refer to surgery, especially if his BMI is more than 40 or more than 35 with combined with obesity-related conditions. If the patient is not fit for surgery, it doesn't prefer to go on surgery, you can go for aspiration therapy or volume reduction like endoscopic sleeve gastroplasty. If the patient, the target weight reduction is low, and if the patient is prefer to put an implanted device in his stomach because it needs cooperation from the patient and follow-up, if he can go for follow-up, then discuss intra-gastric balloons, especially if the BMI between 30 and 40. And if he can't follow up, then you can go to some other procedures with low level of evidence, like Botox injection or duodenal mucosa resurfacing. So in my take-home messages, endoscopic bariatric metabolic therapy have been proven to be safe and effective treatment option for patients with obesity. The reversibility, repeatability, and cost-effectiveness of endobariatric procedures make them an attractive option to fill the gap in obesity therapy between medications and bariatric surgery. Additional endoscopic procedures are continuing to be developed, and innovation in the existing procedure have allowed for improvement outcome and decreased adverse events. Thank you very much.
شكرا يا دكتور جاسر. Any questions؟ أنا أسأل حضرتك الجاستروستومي زي ما حضرتك كنت بتقول إنها ممكن نعمل جاستروستومي ونعمل أسبيريشن. في بعض الحالات هتبقى الأسبيريشن صعبة علشان الابليكيشن بتاع الجاستروستومي لو هو ريكامبنت مش هيحصل أسبيريشن للجاستريك كونتنت. هل ده هيأثر على المانوفر ده؟
هو الجزء اللي بيبقى اللي زي اللي هو الجاستروستومي يشبه الفيدنج جاستروستومي، لكن هو مش فيدنج جاستروستومي. في سبيشال ديفايس بيعمل نيجاتيف سكشن فور اسبريشن. هي المانوفر ده mainly معموله as a bridge for surgery. If the patient is overweight and has many risks to go into bariatric surgery, this will enable the patient to lose 50%, at least 50% of his excess body weight to be fit for surgery.
بالنسبة للsleeve operations surgical, many patients regain the stomach size after 1 year or maybe 2 years. And the endoscopic, I think it's comes early, the restoration yes. of the normal volume of the stomach.
In endoscopy, the magnitude of loss of weight is less than the surgical sleeve. However, it can be repeated. We can shift to another form of endoscopic management. But for surgery, of course, it's not. You can't repeat, and you can't.
This is the advantage.
Yes,
we can repeat it. It's
yes,
repetitivity is probable.
Yes, it's the advantage of endoscopic procedures.
Okay, surgery is not.
Of course,
yes.
شكرا يا دكتور جاسر. شكرا لحضراتكم.